Thank you. And now it's a real pleasure for me to introduce the next speaker, Fabrizio Luppi from Modena, is playing at home, who will talk about the small vessel disease in interstitial lung disease. Thank you, Fabrizio.
First of all, I would like to thank Professor Fabri for the kind invitation, Professor Saetta for the kind introduction. They are two of my mentors, together with Professor Rabe, that is in the audience. The title of my presentation is Small Vessel Disease in Interstitial Lung Diseases. Interstitial lung disease is a very big group of diseases, more than 200, that share at least one feature, which is the pulmonary interstitium involvement. One of them, they have also bronchioles involved, but the pulmonary interstitium is the most important and most shared feature. There are several ways to classify interstitial lung diseases. I'm going to propose you this classification with 5 different categories. The interstitial lung diseases exposure related, they are a very big category. Idiopathic interstitial pneumonia, which is now a hot topic in respiratory medicine, mainly for the presence of idiopathic pulmonary fibrosis, which is usually a very progressive disease with now new antifibrotic drugs. Connective tissue disease, in which the lung involvement is very important because it is the primary cause of death in this group of diseases. Sarcoidosis as a prototype of granulomatosis. And finally, a miscellany of diseases, all at an unknown etiology, to which I would like to stress lymphangioliomatosis, eosinophilic pneumonias, pulmonary lung cell histiocytosis, and vasculitis. Excuse me. The other topic of my presentation are small vessels, and I would like to propose you a classification of small vessels involvement in interstitial lung diseases, dividing them in direct microvascular damage, indirect microvascular damage, and the gray zone. With the term gray zone, I would like to mean a condition in which we don't know if the vascular damage is direct or indirect. As an example of direct microvascular damage, I would like to propose you vasculitis. Vasculitis are a big group of diseases reclassified in 2012, and they can be defined as an inflammatory disease of the bronchial, of the vessels wall. We can distinguish large vessel vasculitis, medium vessels vasculitis, and small vessels vasculitis. In the 2002 update of the classification of vasculitis, small vessels vasculitis have been divided in small vessels vasculitis with immunocomplex deposition in the vascular wall. In this group, there are unknown or very rare pulmonary involvement, and the other group are the ANCA-associated vasculitis, which are microscopic polyangiitis. In the new classification, eponyms have been deleted, so granulomatosis with polyangiitis is the new name for the former Wegener's granulomatosis, eosinophilic granulomatosis with polyangiitis, formerly called Chu-Strauss. But what are ANCA? ANCA is an acronym that stands for anti-neutrophil cytoplasmic autoantibodies, originally described using immunofluorescence and divided in cytoplasmic and perinuclear ANCA. As you can see on the left, you have an example of cytoplasmic ANCA at the immunofluorescence, and on the right, the perinuclear. The difference between P and C ANCA is that they have different antigens. The main antigens for C ANCA are proteinase 3. The main antigen for P ANCA are myeloperoxidase. Are ANCA present in all patients with ANCA-associated vasculitis? Of course, the answer is no, because in medicine there is no test with 100% sensitivity and specificity, but as you can see, the sensitivity of ANCA is greater in granulomatosis with polyangiitis and microscopic polyangiitis, much lower in eosinophilic granulomatosis with polyangiitis. And nowadays, it has been used to divide eosinophilic granulomatosis polyangiitis in ANCA positive and negative as two different phenotypes of disease, but till now without any difference in treatment. We know nowadays that ANCA are also involved in the pathogenesis of the disease. In an inflammatory milieu, we have the priming of neutrophils with the deposition of intercytoplasmatic antigens on the cell surface and in the microenvironment, with binding with ANCA antibodies. This causes the activation of neutrophils with an acute and chronic inflammation, which is at least in part responsible for the pathologic features that you can observe in vasculitis. On the clinical ground, to approach these diseases deserve attention for the stage of the disease process and the distinction between active and damaged disease. The stage it has been conceived by the European Vasculitis Study Group, and vasculitis are divided in limited or localized, usually with an upper respiratory tract involvement. After we have the distinction in early systemic, generalized, and severe. In early systemic, we have involvement of various organs, but any one of that is life-threatening. In the generalized, we have life-threatening involvement, and in the severe form, we have vital organ involvement. And finally, the last category is the refractory disease, in which there is progressive disease not responding to treatment. As you can see, this classification is important because this is mandatory for a different treatment, as you can see in this cartoon. The other very important point, always for treatment and prognosis, is the distinction between active disease and damage. And to distinguish disease activity and damage, I think that is very, very clear, these two pictures. This is disease activity, this is disease damage. And disease activity, which is an important parameter to decide treatment, is based on a questionnaire which is named Birmingham Vasculitis Activity Score version 3, which is a 56 items questionnaire, which is able to see us the difference between a disease which is active or a disease in which there is only damage. Why this is important? Because in the disease activity we have the treatment is, the aim of the treatment is induction of remission. In the disease damage is a maintenance treatment, because these diseases may frequently relapse. Clinically, these diseases have a certain overlap, but certainly even typical characteristics. In microscopic polyangiitis, we have glomerulonephritis, sensory neuropathy, mononeuritis multiplex. In eosinophilic granulomatosis with polyangiitis, hypereosinophilia is a characteristic feature with myocarditis. And in granulomatosis with polyangiitis, we have necrotizing granuloma with orbital pseudotumor, subglottic stenosis, and sinusitis. Focusing on the lung involvement, even in this case, we have some overlap and some differences. It is interesting to know how they can be different as a lung function tests, on HRCT findings, on the pathologic findings, and on the characteristic of bronchoalveolar lavage. But if you want to see some overlapping, at least for granulomatosis with polyangiitis and microscopic polyangiitis, we have diffuse alveolar hemorrhage. What is diffuse alveolar hemorrhage? Is a clinical pathologic syndrome characterized by intraalveolar red blood cell accumulation, originated from the capillaritis process and causing various degrees of respiratory impairment, including adult respiratory distress syndrome, and that's why I think that it's important to spend a few minutes on this. Both chest radiograph and high-resolution computed tomography are absolutely non-specific. The diagnosis may be performed using different aliquots of bronchoalveolar lavage, in which we are able to see a progressive increase in the red, which means in the number of concentration of red blood cells between the first and the last aliquots. This condition, however, is not specific for systemic vasculitis, but we can also find in isolated pauci-immune pulmonary capillaritis, in collagen vascular disease, in Goodpasture syndrome, and in lung allograft rejection. The diagnosis is usually histologic, and so in these diseases a biopsy should be performed, mainly for the potential negative prognosis, for the duration of the treatment, and for the potential side effects of the drug. Going in the disease with small vessel diseases with an indirect musculovascular damage, I selected pulmonary hypertension. I wouldn't want too much on the clinical characteristic because in this room we have three prominent key opinion leaders in cardiology and Professor Nazareno Gallier, which is the leader of the guidelines, but I think that is important for the purposes, for my purposes, to define pulmonary hypertension as a condition in which you have a mean pulmonary arterial pressure which is higher than 25 millimeters of mercury, and when you have a low edge pressure, you have a precapillary pulmonary hypertension, which is characteristic of the class 3 of the WHO, which is the PH, pulmonary hypertension due to lung diseases. The guidelines hypothesized that pulmonary hypertension due to lung diseases may be secondary to hypoxia, which can be responsible, at least in part, for the morphological alteration that you can see in small vessels in this condition. And between the pathology, the diseases of the class 3, we have also interstitial lung diseases. Of course, the clinical meaning of a pulmonary hypertension in a lung disease, it is very important, it is even the level of severity. And when you have severe pulmonary hypertension, as it has been demonstrated in this Scottish retrospective study, you comparing a cohort of severe pulmonary hypertension and lung diseases with a cohort of patients with idiopathic pulmonary hypertension, you can see that the poorer survival is observed in the cohort with pulmonary hypertension and interstitial lung diseases, and this poor survival was driven by the interstitial lung disease cohort, including non-specific interstitial pneumonia, cryptogenic organizing pneumonia, but above all, idiopathic pulmonary fibrosis. All these patients have been also treated for at least 3 months with anti-PH drug, which means vasodilator treatment, and focusing on 3 different outcomes, 6-minute walking test, brain natriuretic peptide, and New York Heart Association functional class, it has been observed that compared to the baseline, all these 3 goals have been achieved in idiopathic pulmonary hypertension. This wasn't the case of interstitial lung diseases, in which we had a reduction in the circulating level of BNP, but both the 6-minute walking test and the New York Heart Association functional class were not statistically significant. And of course, the answer at this stage is why this difference? We don't know probably too much. As a pulmonologist, I would like to stress the fact that in this condition, when you have a lung disease, you can have in the lung unit a vasodilation in a lung unit which is poorly ventilated, and this more than improve can worsen hypoxemia. Just for a clinical example of pulmonary hypertension secondary to lung disease, I would like to mention idiopathic pulmonary fibrosis, which is defined as a specific form of chronic progressing fibrosing interstitial pneumonia of unknown cause, occurring primarily in older adults, limited to the lungs with a histopathologic or radiologic pattern of usual interstitial pneumonia. And although the retrospective nature of this study, there are no doubts that in a population of patients referred to lung transplantation, which means with an advanced disease, there is a statistically significant difference in survival in patients without pulmonary hypertension with a better survival compared to the patient with a concomitant pulmonary hypertension in which the survival is significantly lower. And finally, just a few slides on the gray zone. I utilized as a gray zone a very rare disease, which is adult onset still disease, which is thought as the adult variant of systemic juvenile idiopathic arthritis, very rare, 1 to 3 cases per million. The cardinal manifestations are quite specific, and that's why there could be a prolongation in the diagnosis period, because the differential diagnosis is infectious, malignant, and rheumatic disease, and also because there are no biomarkers in this disease. Pulmonary arterial hypertension may be a complication of this syndrome. The pathogenesis, it is thought to be an inflammatory pathogenesis because there are several cytokines involved. I would like to stress the presence of the higher levels of interleukin-1 beta and higher level of interleukin-6. And although they are only case report, it has been observed in a patient with the diagnosis of adult onset still disease that after unsuccessful exposure to various immunosuppressive regimens, shortly following the initiation of the interleukin-1 monoclonal antibody anakinra, her disease became quiescent and the PAH completely resolved. So there have been a dramatic improvement in pulmonary hypertension in this patient, and in parallel, always pulmonary hypertension was treated, even in a case report, with the tocilizumab, which is a monoclonal antibody targeting IL-6, and also in this patient, there was a significant improvement in systemic symptom right air catheterization and a marked improvement in clinical and laboratory parameters, showing that these two monoclonal antibodies against IL-1 and IL-6, although in a narrative setting, may be extremely efficient in the pulmonary hypertension secondary to adult onset still disease. My conclusions are very, very, very short, because I think that I have been able to show that this is a very dynamic topic, and in this very dynamic topic, I think that the light of our knowledge is rapidly covering the dark of our ignorance. Thank you very much for your attention.
Grazie. Thank you very much for this lecture. We have time for one question. Somebody want to ask? Maybe I have a very quick comment. You said that the IPF is the hot topic now because, first of all, maybe we don't know exactly why, but we have the drugs that they seem to change the clinical history, at least in some patients. So a question could be, putting together your description that I like of disease activity and disease damage, if you want, thinking about the drugs in that sense, is it possible that these drugs are also acting in some kind of small vessel, either pulmonary or bronchial circulation, and maybe this can explain their effect? The drugs that are showing, yes, in IPF.
this is a very difficult question because, as you told, we don't know anything or almost anything about the mechanism of action of drugs. And this is due to a very simple fact, because we know very, very few concepts about the pathogenesis of the diseases. Second, also the pulmonary hypertension in idiopathic pulmonary fibrosis is a very sad story, because we have, when it is severe, the patient that worse clinically, not because of the fibrosis, but because of the increase in pulmonary small circle. So it is a very fascinating, a promising question, but at this stage, we have a few information about how the disease occurred that I think that is very difficult to answer to this question.
Many thanks.